Are you ready to go? Ready? So, we're ready. Welcome back, everybody. I hope you enjoyed the lunch break. We have a very exciting and engaging afternoon for you. And it's going to start looking at integrated care. And I'd like to call on Deirdre Collins, who's going to chair the session. She has the most difficult job of the afternoon because she has to control wild boy Bill from Carlow, which is not going to be easy. But anyway, Deirdre was appointed chair of the board of ICGP in 2023 and has represented the college in Ireland on education, training and standards. The board determines the strategic direction of the college and is responsible for the implementation and its monitoring. Prior to that, she was chair of the college's Education Governance Standing Committee. Her time as chair of Education Governance saw the committee provide oversight for the expansion of the education team and delivering of traditional and blended learning for members in a rapidly changing educational environment. Deirdre is a graduate of Trinity College Dublin, completed her GP training in Dublin, and she's founding partner of a multi-doctor practice in Kilcullen, County Kildare, and she was also my boss when I was an intern in Beaumont many, many years ago. So I call on Deirdre and we look forward to the discussions. Thank you.
Thank you, Tom. You can never get away from your first job, isn't that right, Tom? So, good afternoon, everyone. It is a pleasure, as the chair of the Irish College of GPs, to chair this particular session, which is concentrating on the integration between primary and secondary care. So, as a GP, every day I stand on the front line of care. We used to get a bit embarrassed about that word during COVID, but we really are at that first port of call. We are still the first point of contact for most patients, and frequently we're the ones who continue to walk with them as they navigate that complex journey through the healthcare system. And as I said to somebody earlier on, we're also the ones who go home with the patient. They come back to us from secondary care. So all of us in healthcare, but particularly in general practice, we see patients moving from the clinic to the hospital to the community services, often repeating their stories, facing delays, and sometimes falling through the cracks of an otherwise very capable system. So our session will discuss something that is essential, it's urgently needed, and holds great promise for all of us working in healthcare, but most importantly for our patients. To look at what exists now in integration between primary and secondary care and where it can go into the future. Integration has to be a vision of care that is patient-centred, data-driven and informed, and team-based. It's a system where information flows from general practitioner to the specialists and back to the general practitioners, not just when there's a crisis, but proactively, and where the care follows the patient, not the paperwork. So it offers a path to better outcomes, to greater efficiencies, and a better experience for everybody, for all our patients, but for those of us who work in healthcare. And we all know that achieving this future doesn't come from IT or from AI. It needs people, it takes trust, it takes shared leadership, and a culture of partnership across every level of care. So to start, I'd like to introduce Bill Maher, who is the CEO of the Bon Secours Health System. Bill is the Group CEO of the Bon Secours Health System, and this is Ireland's largest independent hospital group. They have more than 4,000 staff, 500 consultants, and they're treating more than 400,000 patients annually in 5 modern acute hospitals throughout the country, as well as operating a care village in Cork. He's held many senior roles in the Irish public health system, including the Group CEO of the RCSI Hospital Group and of the Group CEO of Sailta, which he established as the first hospital group in Ireland as part of the government's reform of the health service. He previously worked for 16 years in the NHS in a career spanning many areas, including mental health, primary care, commissioning and acute hospitals. He has an MBA, an MSc in health information, a BA in law and in accountancy, and an Institute of Directors diploma in company director. He said to me earlier on, he particularly liked me to mention the fact that he's an honorary associate professor in the RCSI, because he never gets around to mentioning that. He holds many governance and board positions, but he considers his greatest achievement, which Tom O'Callaghan has already stole my thunder on, which is that he is, by accident of birth, originally from County Carlow. And I think people in the room will agree with me that County Carlow needs all the big ups that it can get. And I took the opportunity before I spoke to check Wikipedia. And unfortunately, Bill, you're not mentioned, but maybe you'll get there someday. Thank you very much, Bill.
Good afternoon, everyone. Good afternoon, everyone with feeling. I know you've all had your lunch and you're all thinking, why do we have to listen to anyone from Carlow? But forgive me, I want to take you through a few things here, and Deidre touched on some of them there about integration, be it between public and private hospitals, between ambulatory and acute. I started my first job many, many moons ago in the NHS, actually in primary care community and mental health in particular. So I have a fair bit of background knowledge in all of this. Deidre covered some of this, so I won't spend too much time on it, but my marketing team would kill me if I didn't tell you all about the bonds. So JP put 5, 6, 7 little icons there together. 5 hospitals all around the country. Some of you will be sick of hearing this. We're like Shaw's, almost nationwide. Some people in the audience remember what that's all about. We have a care village. We have over 4,000 of the best staff that anyone could have ever amassed. 500 great consultants. Just for some numbers, in case there's some accountants in the in the audience, we've got about 5 million revenue. But at the center of everything we do is about integration and partnership. And we see over 400,000 people annually in there, and it's our privilege to do that. I thought I'd do a little bit of scene setting. Apparently, David tells me I only have an hour to talk, so I will run through some of this. You all know anyone who works in the health service, be it England or Ireland, or indeed in most of Western Europe, I would think, there's a number of shift-in models of care. Some of us use the phrase shift left. And shift left for us in hospital means how much stuff can you do outside hospital that you previously did inside hospital. And for me, that's about moving to ambulatory care, and it's about moving particularly in the area of diagnostics. I'm delighted to see some of my colleagues from Alliance Medical in the audience. I'll show you a little picture about a joint venture that the Bonds is doing with them there. We all know the challenges about the rising costs of healthcare, always ahead of inflation, and the reimbursement models, particularly for those of us in the private healthcare system. Above all, we know though about demography, and we've heard a number of people speaking today about an aging population. I think it's great to get old, by the way, and I want to stay healthy. And we're talking about, everyone will be touching on chronic disease management, and how do we make sure that there's still life in those years that we're going to live for. There's a number of emerging challenges. I still think we're suffering a little bit from COVID and the capacity constraint issues that introduced. I'm not going to sit and talk about trade and tariff wars, but we live in an environment, particularly if you're trying to raise funds for things, there's a fair bit of uncertainty at the moment. For me, though, what begins and ends everything we do is our patients. And you'll see when I talk to you about our 2025 plan, I put something before patients, if that's not heresy. Because I think we need to protect all of our staff to do the great things that they do, no more so, Deidre, than in primary care and GPs. When you said the front line, you were the front line. We've got a lot of regulatory challenges that we need to face. Public system, and I was a public servant for most of my life, whether it was in the NHS or whether it was over here in Ireland. I came back home to Carlow. I chose to go back to Carlow. I'm going to check Wikipedia later. But we know the healthcare system, the public system is very challenged at the moment, and we have great hope for the new minister and the policies that she's going to to oversee. In the bonds, though, at the heart of all of these challenges, for us was staying true to our founded mission. The Bonds sisters celebrated their bicentenary last year, so they've seen more than COVID in their times, a few world wars, and the Bonds is still here. So I think you all know those challenges. You all know as well the dynamic, I think it's a fair phrase that we use, operating environment that we work in. The problems we face today may well be with us tomorrow, but there'll be new problems as well tomorrow. And we have a curse, don't we? May you always live in interesting times. So healthcare, I've heard lots of people say, well, you know, we can do online banking and we can book our flights on Ryanair. Healthcare is a little bit more complex than that. And people don't die usually if they can't get on the plane. So we need to modernize. We need to use things like AI. We need to implement electronic health records, and I'll talk of that. But healthcare is complex. And the reason it's complex is because we all talk about healthcare as if it's happening to someone else. But at some point, we will be patients. At some point, we'll have been relatives or loved ones of ours will be patients. This is the most important service, I think, that we can ever offer. COVID taught me many, many things. One thing it taught me more than anything else is you can't do this job by yourself, and the partnerships are absolutely key. What it also taught me was you look after your people, they're your best asset. So with those challenges, with that complexity, and you're going to have to humor me now, we have a plan. I've been in the Bonds for 9 years. I can't believe the symmetry of this. I have 15 days left before I leave the Bonds. We have developed 2 major strategies, one called the 2020 plan and one called the 2025 plan. And we're coming near to the end of our 2025 plan. There's a bit of a clue in the title. But we set ourselves, will we do it, JP? Yeah. 1 strategic vision, 5 strategic goals, and 15 strategic initiatives. I had a sore shoulder at the time. I could only use one hand. This was set up, seriously, I had a rotator cuff thing. And these are our 5 goals. Exceptional people. That's the point I was meant to do. Exceptional people. Delivering exceptional care. And my argument is you can't deliver exceptional care unless you have exceptional people. Achieving operational excellence. We want to do it the best that we can to achieve sustainable growth whilst living our mission. That's 15 words as well. If ever you come to my office in City West, the code to get in, 1, 5, 15. Compliance are going to kill me for that. But that's the truth. And I'm gone in 15 days. There you go. We backed ourselves with investment, 300 million investment over the 2025 plan. I'm going to show you where that's going. But what I wanted to do, as we're coming closer to the 2025 plan, is tell you a little bit about each of those goals, and particularly where the integration and the partnership comes in. So we started off with exceptional people. John McPhillips is our CPO. He's there somewhere. We were talking about how do we become the employer of choice? How do we make the Bonds a great place to work? How do we win, if win is the right word, the war for talent? And we did loads of things in the Bonds. I could talk to you all day about the stuff that we've done there. But the thing we did possibly the most was we talked to people. We agreed a plan with them. We got them all in the same canoe, and most of them rowing in the same direction. And we did that through our exceptional care strategies. That exceptional people strategies, that exceptional people delivered exceptional care. And how do we measure exceptional care? I'm a production manager at heart. I love metrics. I like counting everything, but I like knowing the meaning of what we count as well. So we went through quality frameworks. You can see some of the little icons there. You all know JCI. Some of you will know JAG. Some of you will know ISO 50001. Basically, if there was a benchmark that was considered good, we aspired to achieve it. And we set about strategies to deliver all of that. And you can see some of them there. The biggest benchmark for us, though, more than anything else, was what do our patients think of us? So we've used a patient survey system, except we don't survey. We don't do a sample once every year or once a quarter. Every day, we give people the opportunity who've used our services to comment on what we do. And that comes together in something that's called a Net Promoter Score. Those are our figures. If you ask me what I'm proudest of in my time in the bonds, it would be those scores. And as long as we continue to do that, the bonds will always be famous for exceptional care. We also, we're a charity. I don't know if everyone knows that. All of our funds go back into our business. We don't have dividends to pay. We don't have shareholders. It all goes back into our people and into services for our patients. So we want to make the most of the resources we have. We consider ourselves to be stewards in the bonds. One of the things we're well advanced on now, and I see some of our friends from Meditech in the audience, is our electronic health record system. Anything we do in the bonds gets called bonds something. So our intranet is our websites, everything is called Bonsai, BondsBeat, Bonds Connect is our integrated health record system to try and join up the bonds, but also join up our relationships with external partners. The thing I'm probably very proud of, though, is the sustainable growth. And you'll have to just bear with me because these are little pictures of all of the things, well, actually, some of the things we've done. We have a hospital in Glasnevin, and this is where the 300 million went. We have a new day ward in Tralee, and then the one that we're probably getting most recognition for is our new hospital in Limerick. I'll talk to you a little bit about that. That's going to be open on September the 1st. But we're also delighted with our cath labs in Galway, our new cardiothoracic surgery in Cork and robotic surgery, etc. And just spending a little bit of time on each of those. You can see in the background there, this is a little picture of the day ward there. Why am I showing you this? This is our shift to the left. A lot of stuff that we used to do as inpatients is now done as day cases. People come in, they go home. They used to spend, our insurers must love this, they used to spend 2 or 3 or 4 days. They're now in and out. You need the facilities to facilitate that. That's why you've seen us build day wards there. This is a bit about the day ward in Dublin. Of course, for those of you who know Ireland, I'm the group CEO of a hospital in Glasnevin and in Tralee. If I build something in Glasnevin, I have to build a better one in Tralee or I'm in trouble. This is the one in Tralee, very similar, and again, the same shift left strategy. In terms of the new Limerick Hospital, on February the 17th, 2023, we did the sod turning on this. Taoiseach Leo Varadkar did that with us there. Our first patient will be in this on the 1st of September. I can't tell you what I said to him at the time about the Children's Hospital, because I'm now working with the Children's Hospital as well, and happy to do so. But this, I think, is the first private hospital built in about 18 years. You don't do one of these every week. This is about 2 weeks ago, what it looks like. And it's great. Fills me with such pride for all of my team that we've been able to do this. We picked that site in the middle of COVID. And don't tell anyone about lockdown and stuff like that. Behind our hospital, this is a little view, right in the top there, is a clinical services hub. There you go, clinical services hub. This is a 5-story, 10,000 square feet building. This is actually now open. We're starting to move into it. This is where the ambulatory stuff is going on. the ground floor in partnership with Alliance Medical. All of our ambulatory diagnostics is in there. We're putting a PET CT in there. I think that's the first PET CT in the Midwest. And we're putting our consultant suites there. So we're trying to keep stuff out. This is the integration out of hospitals or close to, so we can put nothing but clinical stuff in the hospitals. Does that make sense? I can use better jargon, but that's what Shift Left is about for us. That is a very, very impressive building. To me, it's the essence of integrated care. We're going to hear a lot of phrases into the future about clinical diagnostic centres. We're going to tell ourselves we're great in Ireland. We're actually about 5 or 6 years behind what the NHS is doing. These clinical diagnostic centres will be great for patients. They will make better integrated pathways, and diagnostics will be at the heart of them. One thing, and it just crept in about a week or two ago with Eamon Fitzgerald is here as well, a partnership. I told you at the start, partnerships are very, very important to us. No better partner than UPMC. We have a radiotherapy centre that we run together down in Cork in our hospital down there. And we thought it was doing such a good thing, we're going to do one in Limerick. And a couple of weeks ago, we did the sod turning in there. Eamon, I'm sure this time next year, will be telling you about this opening and what a great difference this integration makes for the people of Limerick. Throughout it all, I've said, we need to live our mission. Whether that, I told you about the bicentenary, about our community outreach programs. We've invested more than 3 million into various initiatives. You wouldn't know about most of them because it's us investing with our communities. We do a lot on pastoral care. We've set up pastoral care symposiums. Pastoral care is an important part of what we do. And I mentioned we like to think of ourselves as stewards of the planet as well as our resources. And before it was fashionable, we were talking about sustainability. This is a great colleague of mine, Paul Foley, recently retired. And what we ended up doing is getting more than 50% of our electricity now comes from a wind farm in Tipperary. And it's actually good value for money as well. And the good news is we're never too short of wind in Ireland. So that was one of the proudest moments again for me. So my time's nearly up. I have one last slide. If you asked me, pull it all together, Bill from Carlow, in one slide. I think the Bunds is a major part of the Irish healthcare system. We've delivered a 2020 plan. You're lucky I didn't show you the hand jive for the 2020 plan. It was a lot more complicated. Our 2030 plan is underway. We'll be here for another 200 years. I'll be gone, but my team will be here. And that 2030 plan will be under construction soon. I think we were a key part of the public-private system during the worst of times in the country, when we all put the green jersey on and we all learned how really important it was to work together. We're always going to have challenges in healthcare. This is why we all get up and come to work here. But as long as you have patients at the heart of everything you do, you won't go far wrong. I hope we continue to be part of the local communities, and I hope we're celebrating our tricentenary. None of us will be around to celebrate that. But if I gave you one message, the Bunds has been about adapting and growing. And at the heart of it, it's been about integration and partnership. Thank you very much.
Okay.
Might stay closer to the podium for the next one. Thank you very much. Bill, thank you very much for that. I think what we all appreciate there is the value of your voice in this conversation, just with your breadth of experience across the private, the public sector, with private funding, public funding, and the primary world, primary care world, the secondary care world. It's so valuable. I was a little bit concerned about your reference to rowing a canoe, but we'll leave you away. It reminds me of Eddie O'Sullivan, the rugby pundit, and this one is for Fintan Foy, who, when talking about the challenges that a team was facing, said that you couldn't fire a cannon out of a canoe. Isn't that right, Fintan? So moving on, it gives us great pleasure to extend a sincere Céad Míle Fáilte to a visitor from North America. Edward Bailey is joining us. He is the Director of Quality and Patient Engagement at Mount Sinai Health Partners. He directs strategic development and implementation of quality improvement initiatives to promote better clinical outcomes for patients and support providers for Mount Sinai Health Partners. This is a large clinically integrated network in New York City. He's a practicing primary care nurse practitioner with experience as an inpatient registered nurse that led him to a leadership career in population health management and quality improvement. His role includes leading patient engagement initiatives for primary care, along with ensuring quality data is captured to optimize quality reporting and to drive financial performance across Mount Sinai's value-based contracts and quality programs. So thank you very much. Very welcome. We look forward to hearing your presentation.
All right, thank you everyone for having me. Thank you, Dr. Collins, for that nice introduction. I'm going to talk to you today about clinical continuity. We refer to it or leakage and keepage, or really care coordination for all of our patients, and hopefully give you some tools to promote outreach and connections with patients. I'll talk about Mount Sinai at a glance, a review, like everyone has a slide of their health system here today. We'll talk about patient engagement to support value-based care or really high-quality primary care. We will review steps to do centralized patient engagement, and also how you can empower your care teams to do engagement as well. So here's Mount Sinai in Manhattan and the greater tri-state area. It started, our signature hospital is the Mount Sinai Hospital on the Upper East Side, and then they merged with Continuum Health Partners in 2013, really to become a much larger network with more hospitals, more ambulatory care centers. And you'll see, speaking to integration, we have several employed physicians, but we cannot do it alone. We have many community partners as well. So we have community-based organizations that we partner with. We have community-based physicians that refer into our network and get the support. We obviously have our hospitals, and then a post-acute care. So we coordinate care with them to make sure that anything that happens after the hospital, the transitions of care are smooth. We have ambulatory surgery centers and federally qualified health centers as well in our clinically integrated network. Within this network, we have a group of patients that we take risk on and have a value-based contract with. And this is really our primary focus to sort of change the fee-for-service model that is in America, where see more patients, get more money. We want you really to see less patients or more time and improve the quality of care that they're having to prevent downstream effects. You can see here half of our value-based lives are commercial patients, so usually patients with higher health literacy, better access to health care, and then the other half are in government-sponsored insurances, Medicare and Medicaid. The different setups we have here are pay for performance, so if we do well in quality, we get some dollars. If we come in under a financial benchmark, then we can share in that money as well. And then we can ultimately take full risk for the patient, where you would get a capped amount of money to take care of the patient through their journey. And if you come in below that cap, then you would get some financial benefit. We're going to talk about patient engagement now, really our operational strategy. You have the patient journey here, their access to healthcare, their behavioral health needs, their social determinants of health, also the quality of care that they'll deliver, and the disease management that they will receive. Hopefully will mitigate or will not have that hospital event, that really high cost event that we all try to avoid, and really manage the transitions of care after that event into the post-acute space and hopefully eventually home. But all of our strategies are really driving in the opposite direction. We want to improve access. We want to identify social determinants of health and work with those community-based organizations to address them. We want to make sure we have behavioral health in the clinics to address those needs that primary care physicians or specialists might not be able to address. One of our most popular frameworks is the shared savings, where we want to see our patients, engage them, bring them into primary care, give preventative care to them. We also want to make sure that we're diagnosing them and with the most specificity. For example, if a patient has diabetes, we want to make sure we code it with complications because that increases our allowable spend for patients to say this is a really complex patient that's going to require a lot of care, and therefore this is what we would expect them to spend. We want to reduce our actual total spend, so we want to keep them out of the hospital, keep them out of those expensive post-acute days, make sure they're happy and healthy at home, and have really great primary care where we're addressing their preventative care gaps, managing their chronic diseases. And if we do that, then there's a financial benefit for our health system and really a benefit for patients to have a better journey in healthcare. Engagement, bringing patients in the door. We know that strong primary care will drive better outcomes. And how are we going to do that? Well, we have different forms of outreach. We have passive outreach, like an email campaign. We're going to send all these patients an email, low cost, pretty quick to do, but will that really drive them into us? Is that really helping them, bridge the gap to care? We have more direct outreach. We could hire a bunch of people and call everyone, but that's really timely and costly, and sometimes no one wants to pick up the phone anyway. But those are sort of balances that we're doing to try to engage those patients. I'm going to bring you through some steps that we go through to launch these patient engagement campaigns. The first step is to identify our patient group. Who do we want to identify? The next is, sorting out their contact information, their preferences, their languages. Then we're going to develop communications for these. So what are we going to say to them? How are we going to make it easy for them to come in, or what is in it for their benefit? And then we like to track the campaign effectiveness at the end to see if this is producing the effect that we want, or if we can. So in one example here, our goal is to bring in patients that haven't been seen this year. So we think about patients over 18. They have no primary care visit in 2025. And then they have no upcoming scheduled appointment in 2025. And this is where we arrive at our outreach group. I know across disparate systems, you might not have access to all of this stuff. So if you didn't know that they had an upcoming scheduled appointment, or you didn't have a claim, we've also sent stuff that's very generic that would just say, you should be seen this year for your annual physical, or happy birthday, this is a time for you to come in. And then we also do outreach based on diagnosis or disease state, and this is an example for patients that have uncontrolled hypertension. We want to look at adult patients in a certain age, 18 to 85, with the hypertension diagnosis. Their last blood pressure is over 140/90. They do not have any upcoming appointment to manage that blood pressure. Recheck it, increase medications, et cetera, and then we have our outreach group that we identify. A lot of different channels to reach patients. Probably our strongest ones are electronic health record and then the portal that can be used there. We oftentimes use multiple channels. We won't just send you a text message saying, would you please come in to see your doctor? We'd also send you an email. So we find that reminders and multi-channel approach is really more effective. There are pros and cons to all of these different outreach methods as well. We have to consider privacy, the data that we have. We usually have a mailing address for most people, but the letters can be costly and slow to get to them. Emails are also plentiful usually and low cost to send, but if we don't have direct links to scheduling or anything that's making it easier to bring them in, and there are privacy concerns to mention certain disease states. We love text messaging these days, but I was also reading in Ireland you have pretty strict consent laws, and that's something that we are challenged with. So we can send very generic messages, but we usually have to verify you in a two-step process before we really talk about your diabetes, for example. And then the portal messaging, we'll go through some examples at the end of outreach using that electronic medical portal, which is free from those barriers because people have to log in. We also want to develop our communications and identify people's preferences, so their language preferences that they might like, how they want to be contacted, do they consent to the text, do they prefer phone calls, do they only want letters. Links to scheduling is also very helpful. This is something that we try to include when possible, or at least direct numbers for them to call. We're always surprised that people wouldn't even know the right number to call, or there's 100 different numbers to call for different people. And then we also want to mention preventative care gaps and screenings, good quality care. So when they come to the doctor, they may bring up their vaccinations, their cancer screenings, et cetera. And then tracking them, we love direct, closely correlated tracking, those links to scheduling. How many people clicked on the link? How many people made those appointments? But that is really sort of the ideal state. We really do a lot more indirect. When we sent this 1,000 patient email, how many did we see an uptick in the appointments that were scheduled? Are we seeing increases in our patient seen rates based on all these letter campaigns that we're sending? And even looking at visits at the end. This is an example of sort of our gold standard of tracking with scheduling links. We sent a campaign out in February to Medicare patients, older adults above 65. Not a huge uptake on the direct link, but you can see it spurred some phone calls. Even though they didn't use the link, they were calling in to schedule. Some commercial patients for annual visits, which is longer, an annual campaign. They had much better adoption of the scheduling links. And then another round with our older adults, slightly better performance there for the use of that. Now, I'll finish by talking about empowering care teams. It's good that us, in the health system or in marketing are doing this, but what can really providers and nurses and care team members do at the point of care? So we want to bring them data and tools to support this right where they're working. We want to develop reporting so that they can drill down to the patients and see, when they have appointments, what disease states they have. Want to, again, create materials so that it makes it very easy for care teams to send, I'm going to look at my diabetes patients and send them this message. And then, of course, training is continuous to let people know how to use these tools and what is available. This is our hypertension dashboard in primary care. So doctors, nurses, anyone who's using the EMR can look at a panel of the patients or the practice that's there. They can use associated reporting, would drill down to the patient list, see what their last blood pressure is, see when their last appointment is, and utilize tools to reach out to them. And those tools are bulk messaging to patients. You can look at all your patients with an uncontrolled diabetes and send them a message that haven't been in 3 months. Please come back to see me. You can also bulk message staff. So you send a group of patients maybe to your front desk staff to call and say these patients need to come in. We have pre-templated communication. So again, trying to help the care teams really utilize these tools by teeing everything up for them. And then we also focus on process measures. So these are measures where we can really track performance, not just, how many patients do you have uncontrolled blood pressure, but when they came in, if it was above 140/90, did anyone recheck their blood pressure before they left? And these are ways that we can really drive improvement. And our training resources, people still love a good email and paper, so we send these sort of automatic from the medical record to providers so they can take a look at it. Again, we focus on process improvement measures and tee up those materials so that everyone can have access to them for patients in them. And we also support our providers in helping with order sets. So in this example for hypertension, preferred medications that have a longer half-life, patient materials that they can click down, really making it easy when you're taking care of them. One more example is for our ambulatory care measures. So this is a group of measure set for all of our ambulatory care providers. They can see how they're doing or their practice is doing. And for breast cancer screening, in this example, they can go down to a patient level list. They can bulk order a mammogram, and they can bulk send a message. So you can say, okay, I've seen these women in the last year. They're due for a mammogram. Let me pull that patient list down. I'll order them all a mammogram, send them all a message. They can schedule online. And this is a way, really, a pathway forward. So in closing, we really need to see our patients in primary care to improve health outcomes. We're all working on digital solutions and tools to help our patients get access to care and make it more seamless and reduce the cost of having a lot of staff. Of course, there are other patients that do require a phone call and a higher touch that will always be there. And then some best practices that we've found: really segment the patient population who you want to target, personalize the engagement as you can, languages, preferences that they want to be contacted, work on all of those technology pieces that will support this, like scheduling links or direct phone numbers, in really empowering your care teams to do this as well, because you're not doing it alone. No, everyone loves to hear from their personal doctor versus just, the health system. And then if you can track effectiveness in the end. Thank you, everyone, for your time today. Appreciate it.
Thank you very much, Edward. I suppose as we listen to you, so many of those things sound fantastic and wonderful. We're very aware, we're very aware, obviously, of the differences between our systems, between North America, United States, and Europe. But yet, at the heart of it, there are so many similarities. And I love the last slide where you put up the picture of the patient and the caregiver, because that's, at the end of the day, that's why we're all here. It's for those pictures and those smiles and those results of caring for the people we want to care for. So it's a great pleasure to introduce next Dr. Dermot Quinlan, who is the Medical Director at the Irish College of GPs. Dermot is also a working GP, as I am, and he's in Glanmire, County Cork. He, prior to being the Medical Director of the ICGP, where he has care of all of the medical training and guidelines and support for our members, both for clinical work and in their daily lives. He was previously the ICGP HSE Primary Care Lead for Diabetes Integrated Care. He became the Medical Director in 2020. He's a Director of the Health Products Regulatory Authority, the HPRA, and he's Chair of their Advisory Committee for Human Medicine. He's a Director of the charity Diabetes in GP. He was conferred with a Master's in Medical Law and Ethics in Edinburgh University in 2018. He has done a lot of work in the past on quality and safety in practice, in particular in relation to atrial fibrillation and stroke, in relation to the prescription of methotrexate with safety. And he was also awarded a fellowship of the Royal College of GPs in 2015 and is currently the chair and the provost of the RCGP Ireland faculty. He was awarded a HRB scholarship a long time ago in 1988, completing an honours BSc in physiology as well as his medical degree. Dermot, you're very welcome. Thank you very much.
Thank you very much, Deirdre. I didn't realise you'd go that far back in my career. Delighted to be here today and to talk really about primary care and integrated care. And really, we had earlier Professor Lebrique from the WHO talking about building on sand and shaky foundations. Irish general practice is built on really solid foundations, and I'm going to address timely access, equitable care, and the value of continuity of care, which really are the hallmarks of general practice. I'm also going to look at our workforce, our GP workforce, and the workload issues that arise, and a brief look at the road ahead. Timely access to high-quality general practice care is fundamentally important from a patient perspective. And general practice is all about our patients. We're going to look at how general practice is incredibly equitable. And finally, we're going to look at the value of continuity of care in general practice. Many of us don't realize, people who are otherwise well and fit and healthy in their adult life don't realize that 80% of the population see their GP at least once a year. So we reach the vast majority of our patients every year. And that gives us a great opportunity to connect with people, to check in with their chronic disease management, their screenings, their well-being, their mental health, their physical health. We look after people really from antenatal care right through to palliative care at the other end of their life. The average visit per GP per patient is 4.4 visits a year. And that's a huge quantum of work. And I know most of you will say, well, I never see my GP 4 times a year. But if you take women when they're pregnant, people who become seriously ill, and particularly our older patients, they will certainly see their GP multiple times. And collectively, that brings about 21 million GP in our contacts consultations per year. So we do a huge amount of healthcare. And in terms of the access to it, the majority of GP practices keep same-day appointments. And I know we hear about patients who have great difficulty getting to see a GP, and we work really closely with the HSE and the Department of Health to expand the GP number so that people can get to see a GP when they need to see him. The vast majority of patients, if they have a routine appointment, they get seen within a week. And I'm very conscious that about a third of practices only accept new patients at the moment. And that is a big challenge for the Irish College of GPs and my GP colleagues. And I know particularly for patients who are moving around the country, maybe young patients in Dublin, it's a particular challenge trying to find a GP. And that reflects that we need substantially more GPs in the country. So if we are to continue to provide timely access, we need more GPs. That's daytime. In terms of GP out of hours, GPs do about 1.5 million consultations per year, and I'm based in Cork, so I have access to the Cork and Kerry data, SouthDoc, and SouthDoc sees about 220,000 patients a year. By way of reference, CUH Emergency Department sees 75,000 a year, so just to give you an idea of the scale. So 220,000 patients a year seen in SouthDoc, and the vast majority are seen and treated within 4 hours. And only 12% of them are referred to secondary care. So the vast majority, 88% of patients who present to SouthDoc are seen, treated and discharged within 4 hours. So certainly in terms of timely access. The GP workload, as I said, our GP consultation is 21 million per year. GP out of hours, a further 1.5 million consultations per year. Emergency department in total per year is about 1.5 million. Outpatients, just over 3.5 million. So general practice does a huge amount of our healthcare on a daily basis, 24/7. But not alone do we do that workload, but it's actually really equitable. And people attending their GP are seen on the basis of clinical need rather than ability to pay. And that is unique in our health service. So general practice care is very equitable. There are some really fabulous changes in our HSE engagement, and I'm thinking particularly of initiatives like the Acute Surgical Assessment Unit, the Acute Medical Assessment Unit, GP Access to Diagnostics, which are increasingly bringing that equity of care from secondary care for making it accessible for patients. And I see Stephen Donnelly is here, and Stephen Donnelly was a driving force in developing the GP Access to Diagnostics. So GPs now consume about 20% of all the radiology diagnostics in the country. The value for that in patients, it means they can get treated in the community as first line to care. But it also brings value to secondary care, where previously for certain conditions, if I had somebody and I thought a sportsman maybe with a torn cruciate, I had to send them to ED or send them to outpatients to get a scan. Now I can get that scan directly in primary care in general practice, and usually within a very reasonable timescale. For patients with, for example, a finding like a torn cruciate, it means that when they see the outpatients, the orthopedic surgeon, they're much further along the diagnostic pathway, which greatly supports secondary care. But as importantly, if they have the scan and everything is okay, they don't actually attend hospital at all. So that helps manage secondary care workloads. So coming back very much that general practice is a very equitable healthcare. And then continuity of care. Many of our patients have the same doctor or attend the same practice for decades. And your GP gets to know you as a person, gets to know your preferences, gets to know when a person is unwell. You know, so you have a parent who rarely comes with their child, and they come and they say, I think my child is sick. And the doctor thinks, well, actually, this parent never comes. They're very experienced. So we get to know our patients really well. We are absolutely aware of the context. We spoke earlier this morning about people living in deprived areas, and Sandra Broderick spoke passionately about areas of deprivation in Limerick. GPs working in that area shoulder that clinical burden every day, know these patients, understand the context of these patients. But what's also important is that there's a lot of really good evidence showing that continuity of care improves patient outcomes, but also reduces healthcare costs. There's a really good study published recently in Norway showing that patients with the same GP for over 15 years had a very substantial reduction in mortality. So if you take home nothing else other than what I'm talking about today, having your own GP and maintaining good links with that GP for many years improves your personal outcomes. People with the same GP have fewer hospital admissions and reduced use of out-of-hours services compared to those who change GPs on a regular basis. So CDM is a game changer for patients. And CDM is continuity of care. 400,000 patients every 6 months. So I estimate that by the end of 2026, chronic disease management will be seeing about 1 million patient consultations a year. And we know that patients who avail of CDM are, firstly, they don't go to hospital outpatients, but also they have far fewer hospital admissions, fewer ED attendances, and fewer GP out-of-hours visits. And who does all this work? This is a photo of our conference in Cork, our annual GP conference 2 weeks ago. And in terms of the numbers, it's quite small. We've about 4,600 GPs and 2,200 nurses. And I put the hospital clinical workforce there by comparison. So general practice is lean and efficient. In terms of consultation numbers, it's about 3/4 of all the consultations. But we do have workforce challenges, and the British Journal of General Practice published twice in the last few years, in 2022 and again in 2024, the workforce crisis in British general practice, which we have all heard about. And we are not immune to that in Ireland. We have 300 GPs aged 70 and over. We have another 300 GPs aged 65 to 69. So our older GPs are predominantly men, and GPs in their 30 to 60 years of age are predominantly women, and 2/3 of our ICGP members under the age of 45 are women. So that has implications for healthcare delivery, health service delivery, and the Medical Council are very aware of this. So it speaks to the fact that we need to look at our GP workforce and expand our GP workforce. Coming then to the workload, the population expansion, which the Minister spoke very eloquently about this morning, we expect to go from 5.2 million last year to 5.5 million at the end of 2025. That extra 300,000 patients mean we need another 300 GPs. Our aging population brings a huge workload, and multimorbidity among these patients brings a huge additional workload. So these are factors that are common across primary and secondary care. And then there are some that are unique to primary care. We have an aging GP workforce, as I already mentioned. COVID-19 has put a further additional workload into general practice. We have still doing COVID vaccines. We're still seeing people with acute COVID. We're still doing long COVID. And the GMS expansion increases the consultation rate for general practice by about 30%. While we welcome the GMS expansion, it does create access issues for patients. Frailty really is what the Minister was mentioning this morning. People aged over 65, and we all know what frail elderly people look like. And frailty is age-related. Patients aged 75 and over, it's 25% frailty. 80 years, it's 35%. And for people aged 85 and over, almost half of them are frail. Frailty is dynamic. It can be prevented. It can be reversed in primary care. It's not resourced at the moment. The marginal cost of frailty is estimated at about €10,000 per patient per annum for the economists among you. The problem with frailty is it increases healthcare utilization. Frail people are twice as likely to attend ED, 3 times as likely to be admitted, and their length of stay they're likely to stay in hospital far longer. They also increase their GP visits 4-fold. So frail elderly patients, and we are delighted my parents are in that category, but they do consume a substantial amount of healthcare resource, and we need to plan how we are going to do that in the next 5 years. One of the big challenges facing us is rural areas. And I bring you down to Kerry and the beautiful Iveragh Peninsula. And the Iveragh Peninsula used to have 4 GPs in Carsaveen and 2 in Waterville. So it had 6 GPs for a fairly stable population. Carsaveen now has 2 and HSE GP locum, and Waterville has gone from 2 GPs to 1 GP, looking after 8,000 patients who are disproportionately older patients and 1,000 IPAs, international protection applicants. So we would estimate that that peninsula needs 8, 9 or 10 GPs, and it currently has 4. I've circled Tralee Hospital, or Tralee, because for patients who can't access their GP on that peninsula, and it's remote and it's a huge geographic peninsula, it has the Carrauntoohil Mountain there, the next available healthcare facility is Tralee ED. So looking at the road ahead, we have 4,600 GPs. We are delighted now, and again with Stephen Donnelly, we increased the number of GP trainees very substantially. So we have over 1,100 GPs in training at the moment. But the patient population continues to expand and age, which is very welcome, but it does mean we need a lot more general practitioners. Access, despite what I said about equality, isn't equal. There are parts of the country, particularly the Western Seaboard and the Midlands, where the number of GPs is as low as 50 per 100,000 patients, vis-a-vis the more urban areas where it's at twice that. So people in urban areas have much greater access to general practice. So in conclusion, general practice is a very solid foundation. We have timely access, it's very equitable, and continuity of care improves patient outcomes. We have an expanding GP workforce. We take an awful lot of GP of work within the healthcare service. The road ahead is very good. We are very positive. There are challenges, but we are confident we can deal with it together. So, thank you very much.
Thank you very much, Dermot. I mean, obviously, in the role that I'm in, a lot of the information that you give us is very familiar to me. It's so important to hear it expressed. Dermot's comment about general practice care is always that we deliver high quality care, but at such a scale. It's so impressive on a 24/7 basis. Thank you very much. We'll come back to the conversation later. So, again, our last speaker is Professor Camilla Carroll, who is the consultant otolaryngologist, ENT surgeon. I'm sorry, I was born before, I was born in ENT time, not in the other one. So it's a great pleasure. Professor Carroll is a consultant surgeon at the Royal Victoria Eye and Ear Hospital in Dublin. She is an elected member of the RCSI Council and a surgeon educator, trainer, and mentor at the RCSI. Her education and assessment profile includes many high-level positions with the Royal College of Surgeons of Ireland and Great Britain. She is involved in the Global Surgery Mentorship Programme with the Association of Women Surgeons and Women in Surgeons in Surgery Africa. Professor Carroll has engaged with the surgical community nationally and internationally in the domain of climate change and health over the past 4 years. In 2022, she was appointed as the RCSI Chair for Sustainability in Surgery and as the HSE Co-Chair for the Green Theatre Agenda. In February 24, she launched the RCSI document Sustainability Principles and Practice in Surgery and the NDTP HSE e-learning Sustainability in Surgery module for NCHDs. She was appointed as the RCSI Council Ambassador for Sustainability in 2024 and is currently developing an NDTP HSE funded training programme for the extended surgical team, which will be piloted over the coming year. So she's going to talk to us about this whole area in a slightly different presentation to the rest of the speakers, and we look forward to it. Thank you very much.
Thank you very much. Thank you, Deirdre. So good afternoon, and it's a great pleasure and honor to be the last speaker today. And I would like you to bear with me a little bit because indeed I am going to talk about the urgent need to decarbonize healthcare through shared care pathways. I'm going to, in this session, explore healthcare decarbonisation in the Irish setting through the lens of the HSE Climate Action Strategy document, the RCSI Sustainability Principles and Practice in Surgery publication, and finally, I will discuss the role that integrated healthcare policy in Ireland can play in delivering green models of healthcare using the HSE ENT model of care for Ireland as an example of best practice. Climate action and health. Today, the Environment Protection Agency in Ireland announced that we currently are on target to miss our 2030 commitment to decarbonising our current requirement with the EU. And we are due to miss this by at least 26%. And it's because of our addiction and our continued use of fossil fuel to use our energy requirements. The Lancet Commission on Health and Climate has issued a warning that an irreversible threshold or tipping point in the Earth's climate system is looming. This will result in catastrophic consequences for both planetary health and population health. Global warming has accelerated since the Paris Agreement on Climate Change was adopted in 2015. And at that stage, it was aimed to limit global warming to well below 2 degrees centigrade above pre-industrial levels. Currently, unfortunately, we are now on track for a 4.2 degree increase in global temperature. Climate change is the biggest threat to population health in the 21st century, threatening to undermine health gains that we have achieved in the past half century. Modeling suggests that 1 person will die prematurely for every 1 to 4 kilotons of CO2 emitted due to the diverse health effects of climate change. And globally, the impact of climate change on population health is unequally distributed, with women and children and people living in low-income countries being most affected. Outdoor air pollution is the major environmental health problem affecting everyone in low, middle, and high-income countries. In the Irish context, the most recent data from the EPA identifies poor air quality as the cause of at least 1,300 premature deaths annually. Shifting from energy derived from burning fossil fuel to 100% clean, renewable energy sources is the solution to reducing air pollution in Ireland and globally. Healthcare is on the front line when it comes to tackling the effects of climate change, especially in primary care and emergency care settings. However, paradoxically, in the healthcare sector, it is a significant contributor to global CO2 emissions, and healthcare facilities and equipment used in healthcare consume significant resources and energy, contributing to carbon emissions. If healthcare was a country, it would rank as the 5th largest greenhouse emitter globally. The European health sector alone accounts for 5% of the region's overall carbon emissions, with the EU contributing 12% to healthcare's global climate impact. Decarbonizing healthcare is a major priority if we are to reach net zero by 2050, and the HSE Climate Action Strategy was published in 2023 with 6 priority areas of focus. And I would like to draw particular attention to number 4, greener models of healthcare. 4 key principles are associated with the delivery of green models of healthcare. Specifically, we wish to empower our population to take an active role in managing their health, which can reduce unnecessary utilization of healthcare and therefore drive down the associated emissions. We want to deliver a lean service, and we want to prioritize the circular economy. These principles provide a framework for delivering healthcare that is environmentally, socially, and financially sustainable. Actioning the delivery of sustainable healthcare at a systems level includes the delivery of integrated care pathways. To deliver truly integrated and sustainable healthcare in Ireland, we must invest in key enablers. The 4 pillars: technology, best practice sharing, case-based learning, and data form the foundation of our approach. These enablers support a digitally connected, community-based, low-carbon health system. We have been on this journey for quite a while, and my colleagues and myself at the Royal Victoria Eye and Ear Hospital initially engaged with Simon Harris when he was the Minister of Health, and I do believe that was 2016. And this is called a maturity curve, so we are quite mature now, and I'm getting older. This demonstrates our progression from episodic, disease-specific care towards population-wide integration. At every point, care is siloed and reactive. As we advance, we incorporate multiple chronic diseases, frailty, and comorbidity into integrated pathways. The most advanced models integrate healthcare, public health, and social care to serve the entire local population. This reduces unnecessary hospital admissions, it optimizes the use of clinical and financial resources, and in the end, it improves long-term health outcomes, thereby reducing the carbon footprint of the delivery of health care. The knowledge network model is a scalable and sustainable approach to integrating specialist care and the dissemination of expert knowledge. This approach reduces the need for travel, centralized services, and cutting emissions and increasing care accessibility. At the center is an expert hub team providing specialist support to multiple local primary care teams. Knowledge is shared bidirectionally, creating a continuous loop, a continuous learning loop. This decentralization of expertise reduces the load on hospitals and enhances community-based delivered care. To achieve a sustainable healthcare system in Ireland, integrated care pathways are not optional. They are essential. The HSE ENT model of care for Ireland exemplifies integrated healthcare by placing an emphasis on accessibility, shared care, and multidisciplinary collaboration. The HSE ENT model of care is a strong example of integrated, sustainable healthcare in action. It enables early triage and management in the community, reducing unnecessary referrals and improving access. ENT services are delivered through shared care pathways with collaboration between GPs, audiology, vestibular physiotherapists, and speech and language therapists. The model uses virtual ENT clinics and telehealth to support timely advice and reduce travel-related emissions. By embedding ENT into primary and community care, it ensures that patients receive the right care in the right place at the right time. This integrated, multidisciplinary approach not only improves outcomes, but also supports a low-carbon, more resilient, health system. So, in conclusion, in the public system in Ireland, through smart use of technology, collaborative learning, and systemic alignment, we can deliver care that is equitable, effective, and environmentally responsible. This is the future of healthcare, and it is one that we can build together. Thank you. Thank you.
To stay. Thank you very much, Camilla. I think what's so important to say, this is very important to all of us. It's very important to our patients. And the way you spoke at the beginning goes to the heart of what we know, which is that health and healthcare goes so far beyond medicines and doctors and hospitals. And I think your talk in many ways inspired us to realise that we can all contribute to that conversation and to the solutions that we need to face.
Thank you. Great.
So we're going to move to a panel discussion. I think I might just move to the far end, if that's okay. Right. Thank you very much. Thanks. Thank you all very much. I might just start with Bill because you happen to be sitting beside me. I was just so interested. It's so funny how you talk. We talk shift left, and of course, for many hundreds of years, left has always been seen as sinister. And as a left-handed person, I can talk about that. But it's just such an interesting phrase about shifting left. I suppose your use of the word shift left is where you're talking about moving it into the community. And then if I move on to the man sitting next to you, we will then say, well, that moves it back into our domain. So I suppose maybe for you to start and then Dermot to follow, how does that work? When you talk about your electronic health record that exists in your system, how does that move back into the ambulatory care? And then how does that connect back to primary care, not just general practitioners, but community care?
Bill?
Start with you,
Oh.
Bill.
I was being interviewed in 1983 in City Hospital, Sunderland, by a legendary CEO who's now known as Sir Andrew Gibson. Before he went into healthcare, he headed up the Irish Bomb Disposal Unit. He always told me that running the hospitals was a lot harder than his previous job. And he told me, running hospitals is easy. All you have to do, stop patients coming in, and if they come in, you have to get them out quick. And he said, go out before you come and work for me and work in community healthcare. That's what he said. That was only 40 years ago. I think hospitals are the most expensive part of the healthcare system when it comes to funding. And I think we really only exist to look after people who need the super specialist stuff doing. The more that can be done shifting left outside can only be good for the patients as long as primary care is properly resourced and it's properly invested in, and keep people out of hospital as quick as you can. So I really value primary care. Some of the numbers that you were putting up there show the volumes of where healthcare is really delivered. And I think any enlightened acute hospital system needs to play a full part in that integration, which is our whole session, and through partnership as best we can with those who deliver care in the right place at the right time throughout it all. So.
Dermot, we know that as general practitioners, we're fully computerised. The hospitals aren't. Where do the challenges lie for us with that?
I suppose in 1983, I was still in school.
Did he say that?
That's not
It was your first job.
Doing my
I
leaving,
was 19.
doing
I
my
was
leaving
19.
cert, it must be said. But we have been electronic since I did my GP training, and it has only grown on that. General practice could not manage the volume of work we do without being electronic. So everything I do is electronic, and increasingly we are now moving towards AI to help with clinical record keeping, and that's only in the last year. You know, all my referrals are electronic, all the blood results come back electronically. Increasingly, all the letters from secondary care are electronic, all of our referrals out are electronic. We are massively dependent on IT in primary care, and have been for decades, I would say. We do need additional resources. There are and I'm conscious that somebody was saying earlier about mental health and the challenges of mental health, and it's great to see the suicides being reduced. But general practice receives absolutely no resource for mental health at all in Ireland. So when people with medical cards come to see their GP with mental health issues, which are very time consuming and complex, there is no dedicated resource for mental health in Irish general practice. The chronic disease management program is really welcome. It's put a very substantial amount of resource into general practice. As I said, we will do probably in excess of 1 million consultations for CDM next year, looking at 8 major physical diseases. So we would like to see that expand. We're very conscious of frailty, dementia, chronic kidney disease, which are hugely expensive diseases. As I said, frailty is enormously expensive for our healthcare service. So we need to look at how are we going to manage having, in the lifetime of this government, 1 million people aged 65 and over.
Thank you very much. Edward, I'm just conscious of time. I was going to ask you, we're fascinated by the amount of outreach you do to patients, and particularly the giving all of their information to the patient themselves. Is there a challenge for your people, for your staff, for your doctors, for your clinicians, your nurses, in the release of all that information to the patient, either from the point of view of them coming back looking for more, or perhaps there being reluctance on the part of the professional for the release of all of that? Is that something you've come across in your delivery of care?
Yes, with our particularly with our electronic medical record portal, it's really sort of increased provider burnout because they're getting a lot of messages from patients, and it's a very popular platform. You can ask any question you want and keep asking the questions. So one of the AI tools we're using is drafting a response to that message, which is not really working that well because it can, but we're really trying. And I think more access to that communication, although helpful, I think it's so key to outcomes that patients understand what medications they need to take, what diseases they're managing, and but there is a cost to that. We also have open notes, so people are a little bit more careful about what they're writing or sort of putting it in plain language. We all have our abbreviations and everything else, and we're really trying to teach people to put it so thinking that a patient will read this and what do you want the plan to be, make it as clear as possible.
Moving on from that to you, Camilla, we talked a bit about physician burnout there, and I think that has to be a key part. I mean, part of your message is about creating a sustainable healthcare system. The people are key to that. We've heard that repeated throughout the day. How do we talk to the people in healthcare about creating that sustainability?
And thank you very much for that question. And before I answer it, I would like to thank Stephen Donnelly, who's in the audience today, for the incredible support he gave us as surgeons and clinicians during the pandemic, and also for facilitating the opening of a refurbished department at the Eye and Ear Hospital. Thank you very much. So emotional exhaustion and burnout is a huge issue amongst all healthcare practitioners in primary care, and particularly for our young doctors and surgeons in training. At RCSI, we have taken this very seriously. We have introduced a program into our surgical training pathway where we empower peer-to-peer support amongst our trainees. That's fine for people being upskilled to talk to each other, but we also have provided professional psychology teams to assist the trainers, and that's me, in dealing with these issues as well. And what you pointed out, the fact that here in Ireland we have a big problem with adolescent self-harm, and the primary care provider is not empowered financially to deal with that problem. So if we don't pay for the product, it's very difficult to keep it going. The HSE funds surgical training in Ireland. Again, the ND, the National Doctors Training Programme, have given us a substantial piece of money to help our surgeons in training deal with emotional exhaustion and become better surgeons to provide patient-centered care. Thank you.
Thank you very much. Thank you all very much for your presentations and for your conversation afterwards. I mean, the key to integration is conversation, which we've had, and the collaboration, which several of us have touched upon as we go along. But at the end of the day, it's people. It's not people and patients, because we, as you said, we're all. It's an interaction. We will all be patients someday. But the key to creating these newer systems is enhancing all of the technology and the IT, AI, all of the other letters we want to use to enhance what we do to deliver good care for all of us into the future. So thank you very much.
Thank you.
And who'd have known Dermot was held back at school?
Very true.
So we'll take a 15-minute break and we'll reconvene after coffee at 4 o'clock. Thank you.
We're off, mate. No.
And I
Well
didn't
done.
mention
Yes,
Solid
very
Rock.
well
well.
done.
Yeah, you're
I
excellent.
didn't sing it.
Thank
Thank
you.
Thank you
Yeah.
very much. Good, Mike. Good work.
No,
So you're all very welcome back. I've got the nod from I don't know if the mic is that mic working? Can you hear me? No, you can't hear me. I'll wait till the mic is turned on. We've got the nods to start, so I'll wait till the mic is turned on. Is it okay? Is it? Testing 1 2 3. Testing 1 2. Yeah, can you hear me? Can you hear me? Okay. Diarmuid O'Shea is my name. I've got the nod from Tom O'Callaghan to get things rolling, and I suppose the first thing. So I'm a geriatrician. I'm the president of the Royal College of Physicians of Ireland. And it's an absolute pleasure to be here today. I nipped out of my day job in the hospital I work in to get here for most of the afternoon session. And it's a brilliant program. And I would like to congratulate Tom on the thread of it, just to hear it. The purpose of the session today really connects on from a lot of what we've been hearing and really flows very nicely from the session just before. Ireland is the first country to be recognised by the WHO as age-friendly. And a movement is now building within Ireland's healthcare system to become an age-friendly health system. And the purpose of this session is very much to see what does a true age-friendly healthcare system look like in Ireland. And crucially, how do we get there? When I qualified in I heard Diarmuid say he was doing his Leaving Cert in 1983. I qualified in 1986. The average life expectancy was 70. It's now 84. The number of people in Ireland over the age of 65 was 150,000. It's now 1 million. The population in this country was 3.3 million. It's now 5.3 and projected to increase. And the number, for what it's worth, I don't know if Stephen Donnelly is still in the room, but the number of acute hospital beds when I qualified was 20,000. It's now 14,500. And that's, when you hear about the talk about the importance of shifting left and care in the community, we've also got to understand that acute care, as has been outlined by previous speakers, people will be using hospital services. So connectivity, access, flow, and an ability to move people safely and quickly back to their place of living is critically important. We're still living, despite all of those changes, we're still living in a time of wars, famines, pandemics. It's extraordinary, really, when you think about it. And the practice and delivery of healthcare and the landscape in which we live has just changed completely. As I said, people are living longer, but expecting more. Science is accelerating from personalized medicine through to genomics. We've heard a bit about digital technology, social media, artificial intelligence, which are transforming not just our lives, but how we access care. And resources which we know are finite are both visibly and publicly being scrutinized in a way they've never been before. So there's no doubt that technology and digital technology is changing and transforming everything we do and what we do in the world. And there are huge personal, societal, and political obligations around what we do in the next decade and beyond. And this is what makes a gathering like this that Tom has pulled together so exciting. Because across the spectrum of healthcare providers, innovators, we heard Bill Maher talk about the private sector and what that has to offer, and about the importance of connectivity, the innovators, the scientists, and the researchers. And that's all on a background of us constantly changing, so regionalisation of healthcare. And what makes the island of Ireland such an extraordinary test site for progress and innovation is that we're an island of 5.3 million people, and if we cannot do it together, why would we expect anybody else to do it? And we've been leaders in the world in doing certain things around, public healthcare initiatives on smoking ban, tobacco, alcohol, all of those things this country leads in. And we should be able to lead in the connectivity and delivery of an age-friendly healthcare service. And that goes right across, and I see Tag Daly in the room, on, from nursing care to community to acute hospital sector. That's our challenge. And it's sort of in that context that this Future Health Summit session on what do we do for health and aging, how do we harness healthcare technology, how do we improve access, how do we improve delivery of healthcare services, but critically, how do we stay age-aware, age-attuned, and age-friendly? So thank you as you come to the end of the day for coming into this session and having listened. You have 4 fantastic speakers to hear from. And I'm going to start by introducing Susan Hanna, who's the Senior Director in the European Region Institute for Healthcare Improvement. She's based in the United Kingdom. She has a background in high care nursing with improvement expertise and experience from leadership roles in both acute healthcare and across the community-based population health. And it's going to be fascinating, Sarah, to hear what you have to say on Age Friendly and kick us off. You're very